My name is Brian. I am the CIAO Program Director, and this is the next in our series of CIAO Time, a quarterly webinar series. And today's topic is Opioid Stewardship. And Philip Coffin, our Medical Director, is going to be leading most of the presentation. So at this point, I'll let him take over, but let me finally say welcome, everyone, and we look forward to presenting and talking with you today. Thanks.
Thanks, Brian, and thanks for being here, everybody. We are excited to talk about opioid stewardship today. Obviously, one of the key topics that got academic detailing really up and running. So we are going to run through a brief introduction of us. We'll go through opioid stewardship and documentation, which we've increasingly come to feel is central to and probably should be a key part of academic detailing messaging. And then we'll do a brief demonstration. If you have questions along the way, please post them in the chat box, and we will try to answer them as we go, or certainly at the end. And again, this is our team. Myself, Rebecca Martinez, Brian Wiley, Bunny Taylor, a writer, and Claire Schutz. And we are excited to help you with any issues that you may have around detailing and opioid management in primary care. So our vision is we want to reduce opioid-related morbidity and mortality by promoting balanced approaches to management. And we do this by collaborating with all of you, with healthcare providers and public health organizations to advance opioid management and chronic pain care. Our website is ciaosf.org, and we have a number of materials there, which are free to access. If you'd like to access them at any time, please do so. Please feel free to use them in your own activities. If you want to adapt them for your own site, just contact us, and we're happy to work with you on that. Our first poll. So I'll read this out so everyone can make sure everyone can get it. Which of the following tools do you use or recommend in a visit with patients who are on long-term opioids for pain management? And this is a select all that apply. So a functional pain assessment, urine drug screening, naloxone prescribing, an opioid risk assessment, review of the prescription drug monitoring program, and review of opioid use disorder diagnostic criteria. All right, we got 20 responses, so that's pretty good. Or I guess we have maybe not a full 20. Actually, I think we do, yeah. So most people selected, frankly, all of them, with the exception of opioid use disorder diagnostic criteria. Adding in opioid use disorder diagnostic criteria is something we've done relatively recently. And we didn't used to consider that as one of the key things, but I've come to believe it is. And so we generally recommend that at this point, but they're all correct answers in this circumstance. All right, so in the event of prescribing, in the event of having a patient with chronic pain, you've got all of the things that you want to do for chronic pain. And the truth is, data on chronic pain are not stellar across the board. The studies for chronic pain are really hard to do. It's really hard to follow people for long enough that you can really know that you're addressing chronic pain. So data on most interventions for chronic pain are really mixed, with opioids included. So this is just one chart. There are additional things that aren't on here, but it was pretty comprehensive at the time we made it. And we tried to break it up into different categories. So movement-based therapies, integrative therapies, behavioral therapies, procedures, and medications. So there's a lot of different things that we can do. This is we actually have these as posters that some providers like to put in their office in order to demonstrate to somebody who's coming in with chronic pain that there are tons of options and a lot of work to go through before jumping to opioids. But when you do jump to opioids, you're going to start with your lowest effective dose. And you're also going to recognize that it ignites a whole bunch of other things that you have to do, or what we're calling in general opioid stewardship. And that is our talk today. We're going to run through these items that are in orange. Briefly, these are assessments, and most things are at least annually. An informed consent or controlled substance agreement, checking the controlled substance monitoring program. You'll hear me refer to this both as a controlled substance and a prescription drug monitoring program. I use controlled substance most of the time because almost all of these programs around the country are actually only monitoring controlled substances. They don't include other prescription drugs. So I can't use this service to see if my patient whose hypertension is still not controlled has picked up the first 3 antihypertensives I've prescribed them. So I'd love to be able to check that. So to have a true prescription monitoring program, I believe Nebraska is one of the only places that has one, would be more clinically beneficial, and rather than the controlled substance monitoring programs, which are more about, frankly, enforcement than they are about medical care. And then prescribing naloxone on a regular basis. We put 2 years just because it expires every 2 years. So in terms of assessments, breaking it down a little bit, there's a risk assessment, assessments of pain and function, assessments of medication adherence and other substance use, that's a urine drug screen, and assessment for opioid use disorder. So in terms of the risk assessment, there's a lot of different risk assessment tools out there. The truth is none of them prospectively predict whether somebody you start on opioids is going to develop a problem with opioids. The best measures we have for that are these 4 items. Having a history of an opioid use disorder, a history of another substance use disorder, certain mental health diagnoses, particularly the personality disorders or access to disorders, and also receiving certain psychiatric medications, in particular the atypical antipsychotics, things like Abilify and Risperdal, things like that. So those are the best predictors of somebody who has started on opioids, subsequently developing a use disorder with those opioids. There's a lot to think about with risk assessments. We don't recommend using a risk assessment to decide whether or not somebody should get opioid medications. You should decide whether or not somebody gets opioid medications based on whether or not they actually need opioid medications to manage their clinical problem. And then once you've made that determination, this risk assessment can be very useful to determine how closely you want to monitor the patient and your threshold to reconsider and adjust course. Most of these slides have some information in the bottom right that tells you where to find them in our guidebook. And again, the guidebook is available on our website. So risk assessment also in general is something you're going to do at the beginning of care or when you receive the patient as a transfer in care. It's not something you want to do, you necessarily need to do with any regularity. Oftentimes you just do it kind of at the beginning or when you've inherited the patient. The pain and function assessment is very different. This is something you want to do on a regular basis. What happens automatically in clinics, as we all know, you walk in and the patient and the nurse asks you, what's your pain on a scale of 1 to 10? And if you want your pain to be addressed, you have to say it's a 6 or a 7. You got to make something up, even though your pain was actually only at night when you sleep, and it's a 10 then, but right now your pain is a 0, but you feel like you have to say something, otherwise you don't have any pain that the provider is going to address. So it's frankly a terrible question. It's called the 5th vital sign, and providers are legally required to respond to a pain score, I believe it's 3 or above, or it's above 3, we're actually legally required to address that in the visit and act as though it is a blood pressure of 200, a systolic blood pressure of 200. So it can be frustrating as a provider when a patient walks in and says, my pain right now is a 10, and they're sitting and laughing and chatting and moving perfectly fine. And it makes you disbelieve everything that the patient's saying. So the problem isn't the patient, the problem is the measure that we're using to assess their pain. It's a terrible measure, especially for chronic pain. So we always recommend the PEG. This is the Pain, Enjoyment, and General Activity Scale. It's 3 questions. It's really quick, and it's been validated, and it's been shown to also be as valid and reliable as something called the Brief Pain Inventory, which is not so brief. It's a long scale, and you can use it over time to detect changes in somebody's pain. So the nice things about it that I like are, 1, it measures the average pain over the past week. And then the other things it does is it measures a quality of life, so your enjoyment of life, and it measures your general activity or your function. So that's really important, because for a lot of patients, my goal for a patient who is really debilitated by their chronic pain is that they can do more with their time and they can do more with their life. So if my pain treatment interventions are working, that means that that patient they've been able to expand upon their activities of daily living. Whatever it is that they want to do, they're able to do more of it with the interventions that I've offered. It is really important to recognize that pain among women and racial and ethnic minorities, and also elderly patients, is often unrecognized, often inadequately addressed. So those are also important issues. We are ready for the second poll. Okay, so this I'll ask, there's a couple of questions here. One asks you to select the pain assessment that reflects the functional impact of pain over time. And then the second question asks when urine drug screening should be performed, with every opioid refill, once before you prescribe opioids, and annually thereafter, in order to find out if a patient should be tapered off of long-term opioids or to diagnose an opioid use disorder. All right, we've got a little over half of people have responded, so we can close this out. All right, so most people were listening for the last few minutes and got the PEG scale. Sometimes we call it the PEG 3, but it's really just the PEG scale, a 3-question scale, which is great. Well done, everybody. And the other question in terms of urine drug screening, most people got the answer that we were looking for, which is once prior to prescribing opioids and at least annually thereafter. And that's generally recommended by guidelines. There's not, we'll talk more about urine drug screening, but there's not necessarily data that it improves care or improves outcomes. It's just what the guidelines recommend. Doing it with every opioid prescription refill, that might be necessary in the event of somebody who's extremely high risk and you're really worried about them. So there are cases where you may do that. To determine if somebody should be tapered off of long-term opioids, we don't recommend relying on urine drug screens alone for that kind of decision. And the same thing with an opioid use disorder. You can't diagnose an opioid use disorder with a urine drug screen. So we will move on to the urine drug screens. As we mentioned, so urine drug screen, also called urine toxicology. We tried not to use the word toxicology because it's that's more of a forensic term, and this is not a it shouldn't be a forensic activity. It should be something that supports patient care. So we're trying to shift the thinking around urine drug screen and think of it less as a punitive tool. Like, I'm doing this as a gotcha to see if I can sneakily find out if you're doing something wrong so I can take this thing away from you. And instead trying to use it like a hemoglobin A1C for diabetes to measure how well somebody's doing with their care. So you're trying to use it to support care. What it does is it finds out if somebody took a substance in a particular window of time. What it doesn't do, it doesn't prevent a patient from developing problems with opioids. It doesn't diagnose addiction. It doesn't diagnose diversion. And it doesn't single-handedly provide justification to discontinue opioids. It is a tool that you should, when you run it, you use it as an opportunity to talk to the patient about the findings. It is really important to know a little bit of opioid metabolism when you're using urine drug screens. This is a very simplified chart of opioid metabolism. It's a lot more complicated than this, but it gives you a little bit of an idea. Oxycodone kind of stands on its own. If there's oxycodone in the urine, the patient took oxycodone. If there's hydromorphone in the urine, which is also known as Dilaudid, that doesn't mean the patient took Dilaudid. The patient may be on morphine. They may even be on hydrocodone. Sometimes patients get wrongly accused of using non-prescribed medications because providers don't know the metabolic pathways sufficiently. So it is really important when you run a urine drug screen that if the results aren't exactly what you're looking for, you talk with the patient. And then you also consider contacting the lab, because the urine drug screen that you run might not be what you're used to, and it may have some odd characteristics to it. There are a lot of false positives in urine drug screens. Amphetamines, for example, can have false positives with some common medications. Some opioids have false positives with other substances. And the lab may be able to give you information, and also may be able to run a mass spectrometry test, which is more expensive, but it's also quantitative. So for example, if you are really concerned that your patient on morphine is also taking Dilaudid because their hydromorphone's positive and you have other reasons to worry about that, then you can send it for mass spec. And if there's more Dilaudid than there is morphine, then that's a sign that the patient is probably taking both medications. If the urine drug screen results are negative for the medication that you think that you have prescribed to the patient, then you got to think about a few things. One, are they actually taking the medication? Sometimes yes, sometimes no. And are they taking a lower dose of it, or at a more infrequently than you anticipated? So oftentimes you may have a patient who is on a little bit of oxycodone with acetaminophen, and they're taking it intermittently, and it's not going to be positive when they show up and submit a urine drug screen. So recognizing that, if let's say they're on a higher dose and you expect it to be positive, sometimes urine positivity can actually change with the duration of use that somebody has been using the product, with their body mass, with the amount they hydrate. There are a bunch of things that can affect this. So jumping on a negative screen and saying you're selling your pills is a really good way to immediately end a patient-provider relationship. It is the opportunity to talk to the patient and try your best to figure things out. On to the third poll. We're moving right along. Okay, so the couple questions here. The first, true or false, every state requires providers to check the PDMP before prescribing opioids. And then the second question, that an opioid use disorder, risk factors for an opioid use disorder include history of an opioid use disorder, history of other substance use disorders, and this is risk factors for developing an opioid use disorder while on prescribed opioids, certain prescribed medications, and a history of mental health diagnoses, and then being a racial minority. All right, the numbers have slowed down, so we can close this poll. So the first question was a little bit tricky. Most states actually require providers to check the PDMP before prescribing opioids, but not all. So that was a subtle one. And then opioid use disorder, we got all the risk factors. They were all true, except of course, being a racial minority. There is racism in medicine, and oftentimes providers may make decisions with biases that they don't recognize. So it is always important to consider that when making decisions, particularly when they're around sensitive topics like this. All right, so we've made it through all of our assessments, and we're on to the informed consent. So most guidelines recommend a patient-provider agreement when prescribing opioids. So this is usually some kind of written agreement. On the left of this slide is an example of that has been really thinned out in order to have large enough text for most people to be able to read. And but the basic idea of it is including what are the goals for the medication, what will the provider do, what will the patient do, what are the rules around refills, and what are the rules around prescriptions from other providers, under what circumstances will the provider stop the medication, patient signs it, provider signs it. Okay, what are the data behind this? The data behind these are, one, most of the patients who have them don't know they have them, and most of the patients who don't have them think they have them. So patients aren't really aware of these even after they've signed them. Two, providers find them to be a major burden and to not actually be helpful in patient care, but they use them for two reasons. One, because they have to, because the guidelines tell them to. And two, it does help sometimes as a sort of a fulcrum from which to initiate a conversation with patients about their opioid prescribing practices. I use them in my own practice for exactly those reasons. They do not have, legal standing. If you use them like a legal document and you just terminate opioids because of a urine drug screen that's not exactly what you think it should be, then you're not practicing clinical care. You might as well just be a computer and you're just checking boxes, which is not a great way to practice medicine. So it's rare that these things should be used strictly as they're written, but they kind of provide a little bit of framework and foundation, and something for the patients to go home with, and a way that you can document that you have discussed the risks and benefits of treatment with opioids with the patient. So I would say at a minimum, if you're not doing these types of agreements, you should document in the chart and provide the patient something in writing that talks about the risks and benefits of treatment with opioids. Okay, controlled substance monitoring programs. This is the chart showing the states that do and do not require providers to access, to check the monitoring programs prior to prescribing opioids. And the frequency is different in each state. Some states require you to check them before every prescription. Other states require you to check them. In California, it's every 4 months, which is some random time period that I can never remember. And it is, so it varies by state. So what are the data behind these programs? the data are really mixed. There are studies that show increased overdose, decreased overdose, no change in overdose. In general, what's pretty consistent is that when you have a program that mandates providers to use it, there is less prescribing of opioids. That's not necessarily associated with reduced overdose. It is in many circumstances associated with increased overdose. So there are some recent analyses and papers that have been coming out that raise a number of potential concerns with these programs in terms of how they influence provider decision-making, oftentimes leading providers to prescribe medications that are not listed in these monitoring programs, such as gabapentin, which has also been associated with some certain bad outcomes, and other substances that may be less effective and carry additional risks. So and it's also been used, the results in these programs have in many circumstances been used to basically kick patients out of care. So the programs also provide for many of these programs also use certain proprietary algorithms to identify patients that are, quote, so there are some significant issues with how these monitoring programs are being utilized around the country. Nonetheless, they do have some value and they are required to be used in most states. So we like to talk about how to use monitoring programs to improve care as much as possible. And the first thing is not to dismiss patients from care based on findings from these programs, but to use the programs as an opportunity to talk with the patient. One of the most valuable things I find with these programs in my care in a safety net clinic is when patients disappear from care. And I can oftentimes figure out where they were. If they were on a controlled substance, I can track them down through this program and figure out what happened to them. So I sometimes use it as a patient locator program. It certainly is important to check because sometimes you can have patients that are bouncing from one provider to another. It can be a sign of a problem with opioids or controlled substances. It can also be a sign sometimes of a problem with care. For example, in California, we had the closure of 29 pain management clinics, and many patients left without care. Many of these patients have had to bounce from emergency department to emergency department. So when they show up, when you look them up now, they're going to look like very high-risk people receiving opioids from multiple prescribers. But that's because no primary care providers will prescribe opioids now, which has left a lot of patients with no place to go. So it's important to talk with the patient and figure out what's going on and not just use it as a gotcha so that you can accuse patients and drop them from care. Moving on to overdose prevention. So in a study that looked at 60 patients that were on opioids for chronic pain in a safety net clinics, 37% had actually stopped breathing or required help to be woken up due to opioids, but almost half of them denied overdosing because they didn't recognize the term overdose. So an overdose in common vernacular is thought of as an event where caused by taking a whole bottle of pills or injecting heroin or something like that. That's what people think an overdose is. So if you took your regular pills and you stopped breathing because you're also taking some other pills and you had to be revived by an ambulance, yeah, it's a bad reaction to your medications, but it's not an overdose because you didn't take a whole slew of your medications. So a lot of people who are taking prescribed opioids may be at risk for a bad reaction, and they may not conceive of it as an overdose. And if we use the terminology of overdose, we can alienate them and stigmatize them in practice. So we recommend using terms like accidental overdose is one possibility. I prefer bad reaction or opioid safety when working with a patient. The other thing when, for example, prescribing naloxone, one of the things we like to talk about is that it's important, these are risky medications, and it's important to have this antidote around them in case somebody else accesses the medications or something totally unexpected happens. We're not going to go into detail in naloxone here because we do in other talks, but briefly we'll run through I believe the only study of naloxone co-prescribing that has outcome data. There are data from naloxone distribution that demonstrate reduced mortality. However, most of the data for naloxone prescribing from clinics to patients on opioids is more of implementation data that shows that, yes, you can prescribe it and it works out okay. This study, which we did in San Francisco, compared patients who got prescribed naloxone to those who didn't. It was an observational study. And in the year following receiving naloxone, there was a 63% reduction in opioid-related emergency department visits among those who received naloxone compared to those who did not, such that prescribing naloxone to 29 patients averted one opioid-related ED visit in the following year. So that would be about cost equal in terms of the cost to the system and the savings to the system. We're ready for the fourth poll. All right, naloxone should be prescribed to a patient and you get to check all that apply. With a prescription for morphine 30 milligrams 3 times a day, who has prescribed opioids and has a history of alcohol use disorder, who uses Xanax that they get on the street, and whose sister overdosed last month. Oh, the numbers are going up fast this time. I like it. Naloxone's always a popular topic. All right, we're slowing down. I think we can probably close it out. All right, so almost everybody voted for all of them, which is great. So the guidelines generally say, higher dose of opioids, so more than, let's say, 50 milligrams a day gets you naloxone regardless. Having a history of another substance use disorder, great reason to have naloxone, especially alcohol, which is another depressant. Using Xanax purchased on the street, so using any drugs that are purchased outside of the pharmacy pathway, they all run the risk of fentanyl these days. So we recommend getting naloxone into the hands of anyone who accesses any street drugs. And then finally, whose sister overdosed last month. So that refers to prescribing to family members. And that is encouraged. And at least in many states, it's explicitly authorized that you can prescribe to third parties, to people that are not themselves at risk, but may witness an event. So it's that's how we get it to the places where people have overdose events. Because usually it's not the person who overdoses themselves who administers naloxone to themselves, although there are a handful of those stories. All right. On to documentation. This is our last section, and then we'll do our mock detailing visit. So I talk a lot about documentation these days, and the reason is because when we looked at administrative actions against MD's licenses for opioid prescribing, the majority are due to insufficient documentation. And this is, historically, I remember looking at a lot of notes from providers 10 years ago who just, the note would be refilled pain meds, and that would be the entire note. We didn't always take great documentation. Now with our electronic medical records, you might write that might be all you write in the note, but your note's still 4 pages long because you've got all this stuff that automatically gets inserted into the note. And there are a lot of smart phrases and a lot of abilities to document in more detail. So we recommend, when prescribing opioids, mostly in order to protect the provider, but also to organize your thoughts and details and make sure you're doing everything you can to keep the patient as safe as possible, we recommend pretty extensive documentation. First thing is really making sure you have a good pain history and you're going through the medications and non-pharmacologic therapies, the surgeries. And this is our example of that first one. So this individual is a 55-year-old cisgender male seen for initial provider visit. So this was an inherited patient. They have bilateral hand pain, which actually characterizes sharp pains and numbness. So really neuropathic pain, worse in cold and rainy weather. They've been on oxycodone, 30 milligrams, 4 times a day for 10 years. So that's 120 tabs a month. They just got tapered down to 100 tabs last month. And although they say they don't want opioids anymore, they didn't agree to the taper and their pain is worse. Their pain is on a 5 to 8 out of 10 on the PEG scale that we talked about. So additional relevant history, you want to make sure you've looked at any imaging that they've gotten, any labs that might be related to it. You've looked through prior notes, and you've got your current pain and your physical exam. So back to our example, this patient had some x-rays years before that showed some erosions in bilateral hands, a mildly elevated rheumatoid factor, unclear significance, some swelling of the distal joints that's consistent with osteoarthritis. They were referred to rheumatology but didn't go. They tried gabapentin before, but it didn't help. So we use gabapentin often for neuropathic pain. So then they were asked about their pain with and without medications, and it's better with medications, but still pretty significant. And then on exam, they had full range of motion and some mild swelling, and with intact sensation, but reported numbness in hands and feet. So then we get into our opioid stewardship. So we want to run through that risk factor assessment, run through the OUD screening, the urine drug screening, controlled substance agreement, the monitoring program, and naloxone. So this patient had a history of alcohol use and of methamphetamine use, and also had schizophrenia on an antipsychotic with good control of psychotic symptoms. On OUD screening, the patient had one criterion for opioid use disorder. So they did not meet criteria for opioid use disorder. The urine drug screen was as expected on all previous dates, but given the high risk, the provider decided that they would do urine drug screening every 3 months. The controlled substance agreement was reviewed and signed, and a copy given to the patient. The monitoring program was reviewed, and there were no unexpected prescriptions, and the patient was given naloxone. So that's the opioid stewardship documentation. We really recommend, at a minimum, having that in any notes for patients on long-term opioids. And then the final piece is to have a plan and to put the rationale for the plan. And in this case, the provider writes, I do not treat neuropathic pain with opioids, and this patient does have some risks. However, for now, I'm going to continue the current dose of oxycodone for a few reasons, because the patient has done well for years, because they underwent a challenging recent taper, because they do not have evidence of opioid use disorder, and because they are a new patient with whom the provider does not yet have a relationship. Because there are risks to stopping opioids, as we know, ranging from increased illicit use to overdose death and suicide death. The provider said that they will work closely with the patient to reduce the reliance on opioids for pain management. They'll repeat the imaging and follow urine drug screening closely. So that is a really robust, hopefully more than any provider ever needs to write for a note for managing chronic pain. That is over the top, everything that you can that you need, but it's good to have something like that. And I actually would recommend, when working with providers, if you can send them a template that they can insert into their Epic smart phrases or whatever system they're using, that actually is a really good detailing intervention, because it gives them something so that they can feel like, if I do all these things and fill all these out, then I'm a little bit protected from inquiry into my clinical care. As long as my clinical care is within reason, if I do all this stuff, I'm in pretty good shape. Whereas if I don't do any of this, if I'm not documenting it, then I could potentially be a victim of regulators. All right. So just to summarize this, there are a bunch of steps that providers are expected to take when prescribing opioids in order to remain compliant with guidelines and laws. Evidence for the interventions is really mixed. Frankly, we know that they function a lot like a prior authorization in that they ration care. So we know that they decrease opioid prescribing overall. And documentation is key to protect the patient and the provider, so that the provider can continue to provide care, because we have a real problem in this country right now in that patients who have been on long-term opioids are frequently being abandoned, and providers are frightened to take on those patients. So it is important that we have ways to safely manage patients that may have an opioid requirement. And please don't forget to put any questions in the chat, even if they're controversial. We're going to do our mock detailing session now, myself and Bunny. And remember, when you're listening to this, as we go through this academic detailing session, the things you want to watch for are, do I do a good introduction? Do I do a needs assessment right out of the gate? And then running through the key messages, handling any objections, and then summarizing, closing the visit, and hopefully in that process of closing the visit, locking in some kind of behavioral change that I think might be helpful for the person that I'm detailing. All right. Hi, Bunny. Thanks for taking the time to meet with me today.
Hi, Philip. It's so good to see you via Zoom. What are we talking about today?
Oh, so we were going to talk about opioids. And actually, before I start, though, how much time do we have?
I wish I could give you more time, but I got like 10, 15 minutes. I was pretty busy in the clinic today.
I'm going to set a timer for 10 minutes so that I don't go, so that I respect your time. So opioids. So how's it going in your practice? Do you have any patients on opioids? Any concerns that I can help you with?
Typically that's not really prescribing practices that we do, and I talk to a lot of my colleagues and they say the same thing, and I feel like we're kind of all in the same boat. But I've definitely seen an increase of new patients that maybe had care elsewhere and they are on opioids or have complex pain issues. And it's not that I don't want to help them or treat them, it's that we're just not in a place to do that really clinically where we're at.
Are you worried about like liability for prescribing opioids?
Oh yeah, I mean, everybody is. I'm not alone in it either, so it's not just me. It's the whole clinic. It's in my friends in different clinics around California and pretty much everywhere. So we are concerned about the legality of it for the provider, but also making sure that we're giving the proper care, because we're not specialists.
Yeah. There's a limited supply of specialists, right? Do you have a hard time getting people in?
Yeah, we do. So we've been traditionally, we have been doing, pain referrals, physical therapy referrals. Sometimes people need, psych help, mental health referrals. But to be honest, there's just not as much resources as we need, frankly.
Yeah. Yeah, and a lot of the pain management providers, I think, won't require the primary care provider to continue the medication prescribing, and they'll just do interventions and things like that. I think it's been a concern with the pain management providers, absorbing too much of the care of the patients in some circumstances. So when you do have patients that are on opioids, what do you do for, how do you manage them? Like, what kinds of things do you do to make sure that you're staying within guidelines?
We try to do our best for, just doing, primary care, what we can do in primary care. So that's redoing a lot of assessments, trying to find, prior diagnoses, release of information. And then because like I said, we're not pain specialists, therefore we do rely on trying to send a patient out for maybe x-rays or to a physical therapist to get a professional, besides us, kind of another, I guess you would say, safety net of diagnoses. So we are treating this person appropriately, but we kind of have a lag time in between all of that happening.
Can I share something with you?
Yes, please.
So I'm going to share something we call documentation suggestions. This is something we're recommending these days to consider if you are prescribing opioids to somebody with chronic pain, and that is to really set up actually something like an epic smart phrase to so that you can cover all the components of the chronic pain issue, if especially, frankly, whether or not they're on opioid therapy. But if they're on opioid therapy, it can be important for some of the liability concerns that you've mentioned.
Oh yeah, I see a couple things here. This kind of really looks like a patient that I've seen actually recently, that was new to me. And all these things like the x-ray, et cetera, we've had the same kind of issue. They were on long-term opioids, and we were kind of struggling with that. Now, what is the PEG assessment? Because we don't really do that in our clinic.
Oh, great. Yeah. So the PEG is something I can really strongly recommend. I'm going to stop sharing and jump to that for a moment. That is a really simple questionnaire. So this, what you're seeing now is our opioids and chronic pain guide, basically. I'll share this with you after the session. But right now I'm going to jump to the pain and function assessments.
Great.
So you mentioned being interested in the PEG. I'm sure you love that question, that what's your pain on a scale of 1 to 10? I think it's every provider's favorite question, right, Bunny?
Right. It's it's a question that I ask, with pretty much every visit. So
and such useful information comes out of that question, I'm sure.
I've worn it out, and sometimes I don't even know why I'm asking it, because especially with complex patients where they have different pain issues, not just one pain issue. It doesn't really always tell me that much,
Yeah. So yeah, most providers hate that question. We find it to be tedious, and especially in patients with chronic pain, really not very useful. So what we recommend is this thing called the PEG, and that is really a 3-question scale. So it's quick, it's easy. You can do it every time you see the patient, and you can review their score with, review the score with the patient before, at the beginning of each visit, and see how they're doing. And, for example, if you were to have a patient that's been on opioids, and you review the score, and then if you're able to start a small taper of opioids with the patient, you can see and you can review their score. And if their score is not going up, then it's a sign that they're doing okay on a lower dose of opioids, and it can really help you work with a patient and guide them in their care. What's nice about this scale, what makes it stand out and be different, is really two factors. The first is that it talks about average pain over the past week. So if they say their average pain was an 8, but they're in no pain right now, it may be because their pain's all at night.
Right.
So you don't have to feel like, oh, they say their pain's an 8, but they're smiling and laughing with me, so that's a load of garbage. So you don't have to feel like the patient's lying.
Right. And oftentimes, I'm fully empathizing with them. We're not trying to brush them off. But I also don't feel very well equipped to just start. You got to understand that this just has not been my practice, and it's been told to me, don't do this. And so now that I'm hearing, you're gonna want to kind of like mitigate some of these risks that patients are having if they are discontinued for opioids. Behavior change is really hard, and so I think I just need some help, getting there.
Yep. I understand. Yeah, it is a hard transition. I think it is important to remember to take care of the patients that are most in need and make sure we don't abandon patients. So I think we're getting close to our time. It sounds like the PEG might be the thing that you're most interested in this case. The one other thing I wanted to mention about it is that it addresses some quality of life and general activity. So it addresses function, which is, I think, what we're all most concerned about, is that our patients are able to do the things that they want to do.
Yeah, I agree. I would love to meet with you again to possibly discuss some other things in, your guidebook. And that's a good place for me to start today. Thank you so much.
Yeah. Do you think you might use the PEG with a patient or two?
I think I can. That one seems easy for me to start implementing, right off the bat. I can definitely do that. And then once I get comfortable with that, I think that maybe we can talk more about prescribing practices.
That sounds great. Thank you so much for meeting with me. I will, I'll touch base. Should I set another meeting for about a month from now?
Yeah, that would be great. Give me a little time to actually do that on a patient or two, and then we can meet then.
Great. Thanks for taking the time, Bunny.
All right. Thank you so much.
All right. What did you think about that? Any thoughts, Bunny, on how that went?
Yeah, I getting the tools as a provider and somebody who has seen these patients. A lot of times, clinically, you're rushing. You are in the nebulous world of like smart phrases and kind of pushing work forward and taking a time out to slowly build in a practice that supports your patient. It's not going to happen overnight, for sure. And so starting with small things and moving forward, I think, is really supportive to providers.
Yeah, thanks. One of the things that we ended up, I think, landing on the PEG as the intervention of most utility in this circumstance. It is a major issue, how pain is assessed, and we all think that the interventions, that the pain question is not great, and this is a pretty simple intervention that can be described and offered to providers. It is, and what's nice about it is it's not specific to opioids. It's actually about pain. Because all too often, I think when we talk about chronic pain, we're really talking about opioids, especially us at CIAO, because we focus on opioids. But providers, when they're addressing chronic pain, need to be thinking about pain and not just about opioid management. Okay, that's all we have for our presentation. I don't see any questions at this point in the chat. Anyone have any questions, anything that they want to post? or if any questions or concerns come up with the larger group. I think Bunny raised something in the detailing session, which was the issue around the what to do with inherited patients on opioids. That's in a separate webinar that we did this past summer, and it's a really difficult issue that we're asking providers to take on patients that other providers have had on opioids. And oftentimes you'll inherit a patient, as a provider, you'll inherit a patient that you never would have started on opioids. And so the question is, what do you do in that circumstance? So I, as that example said, I don't treat neuropathic pain with opioids. I don't think it helps. However, when I inherit a patient who's been on high dose opioids for a long time for neuropathic pain, just refusing to prescribe them is really problematic, because fundamentally stopping opioids is not the same thing as not having started them in the first place. When people are on long-term opioids, especially at a high dose, their bodies change, and it is not an easy thing for them to move on to other opioid, to other therapies, to move off from opioids. Some of the things that it absolutely requires, one of the things it absolutely requires is a trusting relationship with the provider, which you can't have on the first visit. So it takes time to develop that kind of relationship. And it's hard as a provider to feel safe to have that time, because the patient is there, they need their refill, and you're concerned about your license, so you don't want to prescribe an opioid that's going to get you in trouble. So you got to do all this stuff and document really well. You're concerned about the patient because you don't think it's the right care, but changing it is completely different from not having started it. And you also feel this pressure because the clinic doesn't want you to prescribe opioids. The clinic doesn't want you to prescribe opioids to a new patient, so nobody can get opioids. No new patients can get opioids. The insurer doesn't want to pay for the opioids, so you're going to have to deal with a prior authorization. Everything is telling you not to prescribe opioids, and especially this is even a bigger deal with the newer, younger providers who were trained in this don't prescribe opioids era. So it's getting really hard for what are these so-called legacy patients. The good news about this is we're not developing so many new patients and expanding the opioid crisis like we were during the heydays of opioid prescribing. So that's the good news. The bad news is we got ourselves into this problem as a healthcare system, and we have to take care of the fallout from the problem. We can't just run from it, which is what some providers are doing. And I don't blame them as individual providers. Oftentimes it's clinic systems, and there's every pressure left and right to tell them to run from the problem. But as a health system, we can't run from a problem that we created. Quiet group today, no questions. So if there are no more questions, we can end early. I want to thank everybody again for joining us today. We really enjoy having you here, and we are happy to take any questions, any inquiries. We love providing the academic detailing trainings and the technical assistance to our partners, and we're always looking for new partners. So thank you again, and have a lovely afternoon.
Thanks, everyone.
Thank you.